Okay, so we'll first discuss the cardiac arrest. Cardiac arrest algorithm. In other words, what we need to do when we say somebody has a cardiac arrest. So what do we say? When do we say somebody has a cardiac arrest? When there is no pulse, not breathing, or only gasping. That's having an agonal gasp, right? Okay. Now for the cardiac arrest, we have two pathways. Can you see this? The first is for the shockable rhythm. And we have the one for the non-shockable rhythms. For the shockable rhythms, what are the examples of shockable rhythms we have? We have ventricular fibrillation and pulseless ventricular tachycardia. These are the two rhythms we have, right? Very good. For the non-shockable rhythms, we have pulseless electrical activity and asystole. So, for the ventricular fibrillation and ventricular tachycardia, what do we need to do once we see this patient has such a rhythm on the monitor?
You have to confirm.
Sorry?
Confirm.
Okay, so you want to confirm if the patient has a pulse, right? Now, for ventricular fibrillations, you don't need to check for a pulse because it is not a perfusing rhythm. I demonstrated to you earlier on what a patient who has a ventricular fibrillation feels like. The heart of that patient is like this. It's quivering, right? And not effectively pumping blood. So there is no cardiac output. Now, what do you need to do? You need to start CPR first. By default, this is what we do. We start CPR even before we consider shocking the patient. I like to use less of the word shock because shock could mean both defibrillation and cardioversion. So I try to use less of the word shock. Now, we'll use CPR. We start CPR, then we decide to defibrillate. Is that right? We defibrillate. After defibrillating, what next do we need to do?
Check it again. Check pulse.
You need to gain an IV access because it's assumed this patient did not come with IV access from home, right? Okay, so we start CPR. You need to defibrillate immediately and you gain IV access. So what's the recommended energy to defibrillate?
120 to 200 by phase.
Okay, so now we are saying 200 for biphasic or more, right? But sometimes you might be in a setting where you do not even know the exact defibrillator or the monitor you're using. Is that right? So what do you want to do in such a situation? Thank you. Beautiful. Just go to the maximum energy you have. I like to describe the ventricular fibrillation as a thief. You know, when a thief comes to one's house, the thief comes to either steal, to kill, or to destroy things, right? Will you pamper the thief and ask the thief, do you want some glass of juice or a cup of coffee? Do you do that? No, you don't. What do you want to do? You want to immediately what? React, right? So that is what I encourage. For ventricular fibrillation that is doing this to the heart, you don't need to pamper it with less energy. Go to the highest of whatever you have and shock it. So we have CPR, defibrillation, gain IV access, okay? Then after 2 minutes of active CPR, by active CPR, I mean CPR without having to look at the monitor. You have no business with the monitor of the patient because whatever you're seeing on the monitor is as a result of your own compressions, your efforts. So do not look at the monitor. CPR, defibrillation, IV. 2 minutes after, you do a rhythm check again. If you still see a ventricular fibrillation or a pulseless ventricular tachycardia, you start CPR immediately. What else do you do? Defibrillate again. Okay. And then what do you do next? Because you have gained an IV, you want to consider giving epinephrine. How much epinephrine is recommended? Beautiful. 1 milligram of epinephrine, 1 mg. That's it. After 2 minutes of active CPR again, you do a rhythm check. If you find a ventricular tachycardia, please check for a pulse. If you find a ventricular fibrillation, you do not need to check for a pulse. It is not a perfusing rhythm, so you need to immediately what? Start CPR again. What do you do next? You need to defibrillate, please. The recent science has encouraged the one shock protocol for ventricular fibrillation and pulseless ventricular tachycardia. One shock protocol. What does it mean? It means that in every cycle, you must deliver a shock. Do you understand? In every cycle of ventricular fibrillation or pulseless ventricular tachycardia.
From the beginning?
From the beginning. CPR, defibrillate. Once you have confirmed it's a shockable rhythm, you have to defibrillate. Early, rapid defibrillation has been found to even triple the victims or the patient's survival. Do you understand? That's the one shock protocol. So CPR, defibrillation. Then what do you consider next? Okay, now I'm going to put it this way. You could decide to give amiodarone. You could decide to continue with epinephrine. And you could also decide to replace this amiodarone. If you considered amiodarone, you could also decide to use lidocaine. Do you understand what I've just done? You can use either amiodarone in this third cycle, or epinephrine, or this amiodarone can be replaced with lidocaine. Lidocaine was introduced last year. Think about October or November. It was introduced into the algorithm for shock refractory ventricular fibrillations or pulseless ventricular tachycardia.
October 2018.
2018, yes. What does it mean to be refractory?
Resistance to response.
Sorry?
Resistance to response after.
Resistance to response. It does not respond to shock or defibrillation, right? Very good. So, in other words, we are saying that for shock refractory ventricular fibrillation or pulseless ventricular tachycardia, the second dose of epinephrine, this is the second dose, it can be replaced with amiodarone or lidocaine. So one of you or two of you might decide to replace this second dose of epinephrine with amiodarone. You're correct. You could also decide to follow this pathway, defibrillation, or you have given epinephrine. This is Dr. Moda's pathway. He's giving epi, he's giving amio, he wants to give epi here. Or Dr. Trillock's pathway could be epinephrine, amiodarone. Do you understand what I'm doing here? Choose whichever pathway you want to follow. The AHA recommends that for shock refractory ventricular fibrillation or pulseless ventricular tachycardia, that the second dose of epinephrine or the third dose of epinephrine can be replaced with amiodarone. Is it clearer now? Or lidocaine. Either you use amiodarone or lidocaine. How does amiodarone work? How does lidocaine work? These are two very potent antiarrhythmic agents that usually reduce ventricular Purkinje fiber stimulation. You know, initially the heart was quivering like this in ventricular fibrillation, right? Now you've started CPR. started CPR, you're getting cardiac outputs, right? When you stop CPR, equivalent continues. So you considered to give what? To defibrillate, right? You have defibrillated. The next you considered to do was to gain an IV access. You have gained IV access, you start in the second cycle. CPR, keep doing, keep doing. At some point, you considered defibrillating again to terminate the arrhythmia. It was stubborn. You considered to give epinephrine, which is also an anti-arrhythmic agent, right? Mostly it's a vasoconstrictor. So it helps to increase peripheral circulation. You have given it. Epinephrine doesn't work for it. Now the AHA is advising that in the third cycle, the second dose, instead of using the second dose of epinephrine, consider giving amiodarone, which is an anti-arrhythmic agent. That will go to the Purkinje fibers. These are the Purkinje fibers, and it tells the Purkinje fibers, relax, relax, relax. So that when you hit on it again, it picks up. Does it make more sense to us? So that is what happens. This is the analogy I used to describe the physiology that happens with introduction of the amiodarone. So now you have given amiodarone or lidocaine. How much lidocaine is recommended?
1 to 1.5.
Beautiful. So this epinephrine is 1 milligram. Okay, we've written it over there. So we have amiodarone. First dose is how much? 300 milligram. Lidocaine 1 to 1.5 gram. Okay? Then you keep doing this. The next one, CPR again. You need to defibrillate again. What do? Epinephrine. So you can decide now to give, this is your own pathway, doctor. Epinephrine, amiodarone, epinephrine. The next can be amiodarone again. So you can give amiodarone here,
150.
or exactly 150 milligrams. Or you decide to give epinephrine like Dr. Trillock, epinephrine, amiodarone, and this will be epinephrine. Do you understand what I'm doing here? Is everybody clear? Right?
After the second shock, epinephrine. After the third optional.
After the second shock, you consider epinephrine.
After the third optional, lido, epi, lido. Sorry, amiodarone, lido, epi.
You don't use amiodarone and bring in lidocaine.
No, I mean optional, easier to remember.
Yeah,
After the second shock, epinephrine.
Okay.
After the third optional, 1 of the 3.
exactly. That's it. In fact, that's it. After the second shock, you consider epinephrine. What is that? And after the third shock, you consider either of these.
Optional, 1 of
Optional. Now, when you start with amiodarone, you continue with amiodarone. If you started with lidocaine as an antiarrhythmic, please continue with lidocaine. Don't bring in amiodarone into
For
it.
loading and maintenance.
Exactly. So for loading dose and then the maintenance dose, okay? All right, so you keep doing this. So CPR, you defibrillate. Okay, so we gave epi here, amio. This one will be epi, right? Now you've given epi, amio, epi here. This will be amio, right? This is Dr. Trillock's pathway, okay? And how much amio will you consider here?
Infusion. After the second.
150 over how long?
We give here 150 before.
We've given 150 here.
The first one.
This is 150. This is Dr. Trillock's pathway. Epinephrine, amiodarone, epinephrine. The next will be amiodarone. So this is his own first dose of amiodarone.
No, given this one.
No, that is separate.
This
This
one
is your
is
part.
300.
No, this is for your own pathway.
Oh, okay.
That's your pathway. We have different people in this class, right? It's optional what you decide to use. Okay? Now, for convenience sake, that was why I presented this, because some people in their resuscitation they get confused about it. Which drug to introduce from after the second cycle? Okay, so now you can decide to ignore every other thing from these other ones I've written and follow this pathway: epi, amio, just like that. Maximum dose of amiodarone is how many? 3 doses. First is 300, second is 150, the third is 150. You stop for the day for 24 hours.
What's that 600 milligrams?
600 milligrams for 24 hours.
Without an infusion?
Without infusion.
Without it.
Okay? Now, if you're going with epinephrine, amiodarone, so it means you have to consider epinephrine. You are giving amiodarone alternate to epinephrine. Is it clear? Beautiful. So now, after this, you need to consider, let's say, ROSC is achieved. What is ROSC? Return of spontaneous circulation. Once ROSC is achieved, then it means you have to now follow what we call the immediate post-cardiac arrest care. I call it PCAC. Post-cardiac arrest care. And then you need to seek expert consultation, and then you transfer the patient to the ICU or coronary care units, as the case may be. Is it clear? Clear? Very good. Now, what about for that patient that is having a non-shockable rhythm? Beautiful. So you need to start with CPR, and again IV access. You need to consider in the second cycle, you need to consider what? CPR, epinephrine. Remember we said it's a non-shockable rhythm. After another 2 minutes, you see the role of the recorder is very important in every resuscitation to be successful. Very important. Now the recorder will always prompt you when it's 2 minutes. Then you stop, you switch roles, you analyze. Do not look at the monitor once CPR is actively going on. Now you have what next? CPR. After 2 minutes again, you do CPR, you give epinephrine. After another 2 minutes, CPR. You keep doing this until ROSC is achieved. When ROSC is achieved, you follow the post-cardiac arrest care and then seek expert consultation and shift the patients to ICU or the CCU.
This one, epinephrine, not in every cycle?
Thank you. Very good question. I was expecting this question to come up. Now, if you notice here, we gave epinephrine after the first epinephrine. We considered it again. We said it was okay to give. Meanwhile, the AHA recommends 3 to 5 minutes, right, for every dose of epinephrine. Okay. Meanwhile, here we did CPR IV access, CPR epinephrine, CPR epinephrine, CPR. You keep doing CPR epinephrine, CPR, just like that. Why? That was the question Dr. Moda asked, and I'm going to give an answer to that. If you look here, it is after every 2 minutes that you switch roles, you reanalyze the rhythm, right? And then consider giving epinephrine. After another 2 minutes, you do the same again. So you see that you have a space of 2 minutes after the administration of epinephrine to reanalyze the rhythm, defibrillate, and consider giving epinephrine. So before you consider giving, is almost the 3rd minute to consider epinephrine again. So you have time, you have this activity there, which will prolong it almost 3 minutes to give another epinephrine. Clear? But here we said we have only one activity, which is CPR. It is not enough to wait for the next dose of epinephrine, right? So we have to wait for the subsequent cycle. Is it clearer now?
Yes.
Good. So this is the cardiac arrest algorithm. Now, and a very, very important question should come up. What's that question? Somebody should ask me, where does the H's and T's come up here?
Where, huh?
H's and T's, the reversible causes. What are the H's and T's? Let's review it again. 1, hypokalemia, hyperkalemia, hypovolemia, hypoxia, acidosis. Very good. So where does it come up here? Where do you need to introduce it? Now, I always recommend that after considering amiodarone or lidocaine, because look here, this patient has a shockable rhythm, VF or pulseless ventricular tachycardia. You have started CPR, you have defibrillated, you have gained IV access and withdrawn blood for studies, right? Now, in the next cycle, you're giving CPR again, defibrillation. You have defibrillated, you have given epinephrine, it doesn't work. You've considered it again here, CPR, defibrillation, considering an antiarrhythmic agent now. Once you know that this patient has been shocked twice, and after the third one, it still does not revert the rhythm, please introduce your H's and T's, discuss it amongst your team members. Okay guys, so what are you thinking? What could have led to the arrest of this patient? It is ideal you consider it. What about for the non-shockable rhythm? When do you introduce your H's and the T's? I always recommend after the second cycle, discuss it. You can discuss the H's and T's all through at intervals. You don't have to stop CPR to discuss H's and T's, right? So you can act as a team leader. So what are you thinking? What could have led to the arrest of this patient? Because the earlier you attend to that reversible factor, the better it is for the patient. Is it clear? Good. All right. So we're going to discuss now the immediate post-cardiac arrest care, which is here. Okay?
This is the way written here for non-shockable. It not looks so clear as you explain here. Yeah?
It's not so clear over there?
Yeah, not the same way. The one who read this.
Everything you have here is the same you have there. I just made it simpler. Now let me see. Let's do it this way. If I have to, Dr. Muda, if I have to take this off, take all these off, you have a single pathway.
No, not this one. We need
This
it.
one? So what do you want to consider a non-shockable?
The one who did this part, he understood that every cycle is epinephrine. This is my comment here.
Every 3 to 5 minutes. This takes 2 minutes only, so you can't give it in every cycle. It takes every 3 to 5 minutes. This is 2 minutes here. Let's put
This
it.
is a clear, I understood it, but I mean the
Then
way
do
it's
5 and
written.
2 CPR.
Yes, that is why I've made it so simple. Yes, if you follow this pathway, it is the same thing you have over there. Okay?
Yeah.
I've just simplified it, and you appreciate it better even when we do the bradycardia and the tachycardia. That's the essence of this. The essence is to simplify resuscitation, because a lot of times we take it to be so complex. Okay? You can have photographs of it if you wish to. Yes. Come. Okay, thank you very much.